Hi, so once again, I'm Laure Fournier. I work at a Paris academic hospital in France, and I'm here as a representative of the European Society of Oncologic Imaging. And I'm going to talk to you about the ORADS, which is used to characterize ovarian masses on MRI. So what is the ORADS? Well, it's the BI-RADS, I guess, of ovarian masses. What's very interesting is that it is the end actually product of a long procedure which allowed first the determination and then the validation of imaging signs that can allow reliable characterization of ovarian masses. And it is so reliable that it is used daily to guide therapeutic management. And we're very proud to say in France that this is the work of one of my colleagues, Isabelle Thomas-Nagara, that she started when she was doing her PhD, so a little over 10 years ago. Let's start with the epidemiology of ovarian masses. You know that ovarian masses are very frequent, but that you will actually have two very different situations. In premenopausal women, most of the masses will be functional. And therefore it is important when they are discovered to do a follow-up ultrasound just to make sure that they don't disappear. There will only 1/3 of them be organic, but among those, about only 1/4 of them will be malignant masses. So the majority of them will be benign. What's interesting is that in postmenopausal women, though there can be a few functional lesions, which are actually rather for recently menopausal women, let's say, most of them are going to be organic, but you still have that kind of 3/4, 1/4 separation between benign and malignant. So about a little over 1/4 of the lesions only will be malignant. So that's interesting to know that also in postmenopausal women, when you discover an ovarian mass, well, there's actually a higher chance of it being benign than malignant. Maybe we should summarize this in another way. The issues around developing reliable imaging criteria to stratify patients are, first of all, that over 75% of patients that are going to be operated on that have ovarian lesions are actually operated for benign lesions. Okay, so that means that maybe some of these operations could actually not be performed, especially since 10 to 30% of those lesions are actually functional. So these are patients that actually should never have gone to surgery. That's the first thing, and that's the kind of argument to say we should be able to reliably detect benign lesions. The other side is that when you do have ovarian cancer, it is asymptomatic. And so when you discover it in a majority of patients, in about 70% of patients, it will be discovered at the stage of peritoneal dissemination. So this should also be a preoccupation. And when you look at an MRI and you see a lesion that is very suspicious, then you should definitely go look for that peritoneal dissemination and make sure that you don't miss it. What are the imaging techniques that we can use for diagnosis? Well, the first line technique will be ultrasound. It will not be MRI. And I'm not going to go into this because it's not the purpose of this talk, but if you are familiar with them, you can use the IOTA simple rules that define a certain number of lesions of imaging signs that are considered as in favor of benign lesions and a certain number of imaging signs that are in favor of malignant lesions, and according to whether there are only benign signs or only malignant signs, then you can stratify the patients. This is actually a quite efficient way to work on ultrasound, and it has about a sensitivity of 90% and a specificity of 80% for the detection of ovarian cancer. So basically what will happen after ultrasound is, the first case is that it might be a typically benign lesion on ultrasound. It can be functional, it can be a simple cyst, it can be a hemorrhagic cyst, an endometrioma, a teratoma, or a non-ovarian lesion. In that case, you will not go to MRI, you will either do a follow-up on ultrasound or nothing. But if it does not go into one of those categories, then it is considered an indeterminate mass. And in that case, that is when you have to perform an MRI. There are actually other cases when you have to perform an MRI is if the lesion is too large and the cutoff is set at 6 centimeters, because then you consider that you might not have correctly explored it using transvaginal ultrasound. The French recommendations are actually the following, and we've published something, and both Isabelle Thomasin and myself have participated in these recommendations for the management of ovarian masses and ovarian cancer. So the way you're actually going to do it is do a first pelvic ultrasound. If it's abnormal, you might want to either do a follow-up or send the patient to an expert ultrasound center. If there's a benign aspect on ultrasound, then there will not be a further follow-up. If there's peritoneal implants, then obviously it is a malignant tumor and you will actually not need an MRI. You will go directly to a CT for staging. And if it's indeterminate with the criteria I just gave you, you will perform a pelvic MRI. If it's benign, then you might just perform follow-up or eventually surgery, but at least a surgery where you know it's benign. And if it's malignant, then you will go back to CT for staging. So what is this MRI that you will be, like how are you going to work on MRI? Well, the good thing about the ORADS, as I said, is that it will give you an algorithm to read your MRI. And if you go through this algorithm, well, you will find that you actually have very good performance in determining whether a lesion is benign or malignant. So how do you analyze an ovarian mass on MRI? First, I'll give you a few technical considerations, and then I'll go through the ORADS classification system. So the MRI protocol must include a sagittal T2 weighted acquisition on pelvis, an axial T2 weighted that covers both the abdomen and the pelvis, just like in the endometrial and cervical cancer. You have to go up to the renal hilum or the renal veins. You will do a T1 weighted imaging with and without fat suppression. You can replace this by a Dixon. And you will do axial diffusion weighted imaging, both on abdomen and pelvis. Usually the easiest way is just to copy the slices that you did on your T2 weighted. And it's very important, your B value must be at least 1200. Then you will do a DCE, dynamic contrast enhanced, or perfusion acquisition, which is basically a 3D T1 gradient echo sequence with a spatial resolution of maximum 15 seconds. And lastly, you will do a T1 weighted with fat suppression post-contrast acquisition. We usually copy the Dixon or the pre-contrast T1 that we did, and I suggest that you do subtraction because once in a while this will really help you. So what is this perfusion sequence I'm telling you about? Well, it is a sequence where you will acquire a certain volume. Here's a film to see. A certain volume over and over again at different time points that will cover the ovarian lesion, and you'll actually keep on acquiring the sequence before and during contrast injection. So I'll show you this again. The lesion is here, and you see it enhances progressively during the acquisition. This will allow you to perform enhancement curves, which we will see later. So why is it so important to do these diffusion and perfusion weighted images? Because, well, if we put together all the literature, what you find is that when you use traditional sequences like T2, T1, T1 with gadolinium injection, you have a pretty good sensitivity of detection of ovarian cancer, but you have a bad specificity. And this is what we used to do, and that's one of the reasons why so many benign lesions were operated on. If you add diffusion, you see that the specificity goes up. If you add only perfusion, well, the specificity goes up a bit the same. But if you add both of them, then you definitely have additional information which will allow you to correctly identify benign versus malignant lesions. And that's really important for the surgeon, because the way he's going to organize his surgery will be determined on the what we could call pre-test risk of it actually being a cancer. And when we say it's benign, usually we're right, and that's very good for him because he can go into the operating room with full confidence that he will be able to perform surgery. So how are we going to go about diagnosing these masses? Well, the first question you're going to have to answer is whether a mass that was described was truly ovarian. And how do you do that? Well, first of all, you look for the ovaries elsewhere. And here I'm showing you a lesion where we saw a cystic lesion here on ultrasound and thought that it was ovarian. And you can see on the MRI that the ovary is actually further away, so obviously it's not an ovarian lesion. If there is a lesion, you will look for ovarian parenchyma in contact, and if there is no ovarian parenchyma, then you can follow the ovarian vessels, and if the vessels terminate inside the lesion, then there is a good chance that it is actually an ovarian lesion. Once you've determined it is ovarian, the next question will be, is the lesion cystic or is there solid tissue? If there is absolutely no solid portion, then it is always a benign lesion. So it's very important to go look for that solid portion. And when we talk about solid portion, we're talking about anything that is basically T2 intermediate signal. But among these solid portion, and this is sort of to be used in parallel of the definitions in ultrasound, there are two different types of solid portions. There are the ones that do not enhance after gadolinium and that are actually debris, for example, blood clots or sediments, and these are benign lesions. If the lesion enhances after gadolinium, then it is definitely solid tissue. It's the same sign as when you put the Doppler on ultrasound. The important thing to understand is that even though there is solid tissue, it does not have to be malignant. It can be either benign or malignant. So in summary, if there is no solid tissue or if it's strictly cystic, then it will always be benign. If there's solid tissue, it can be either. So on MRI, just to show you the difference between what we call a solid portion that does not and enhances in gadolinium, I'm showing you two different patients. One has a right ovarian lesion, the other has a left ovarian lesion, and you see two items here that have intermediate T2 signal inside these cysts. After injection, you can see in this case there is absolutely no enhancement of the portion, so this is not solid tissue. This is probably a blood clot. In this case, there is enhancement, so this is solid tissue. And in that case, we're going to have to characterize this solid tissue. You see how important it is to look at the gadolinium sequence, the post-contrast sequence, to know whether it is solid tissue or not. What about the cystic part? Well, you have to determine what kind of cystic lesion. Cystic is used in a very general sense. So it can mean that there's a fluid content. So if it's a fluid content, it will be high T2 signal, low T1 signal, and absolutely no enhancement post-gadolinium. Okay, so in this case, it can be a unilocular or multilocular cyst, but it will always be benign, okay? Fluid content. Another cystic lesion is hemorrhagic content, okay, with no solid portion. Okay, this could be a hemorrhagic cyst or endometrioma. Okay, what will it look like? Well, on T2 it can have diverse signal. On T1 there will be a high signal, and if you do fat suppression, the high signal will persist. And this signs the fact that it's blood. Okay, but with no solid portion, you absolutely know that this is benign. Another type of content is a fat content, okay? Once again, no solid portion. These are teratomas. You know it's a teratoma if there's fat in there. So fat presents as high T2 signal, high T1 signal, but low T1 signal after fat suppression, okay? So once again, if you see this, then you know it's a teratoma. Be careful, teratomas can have solid portions. Here is a lesion with high T2 signal, but also some kind of heterogeneity. On T1, high signal, plus this portion here that we're going to talk about. Fat suppression shows that there is a low signal where there used to be high signal, so it's definitely fat, so you know it's a teratoma. And after injection, you can see a portion of it that enhances. You should not worry about this. This is the Rokitansky nodule. That happens inside teratomas as long as it looks something like this. Okay, as long as you don't have a mass associated with the teratoma. Now, once we've been through the cystic portion, let's talk about the solid tissue. So what do we mean by solid tissue? And once again, remember this means that it enhances after gadolinium injection. Solid tissue can either be thickened septa, more than 3 mm thickness, papillary projections, a nodule or a mass, or it can be a completely or practically completely solid lesion, and it is considered as a solid lesion if 80% of it, at least 80% of it is solid. But whatever the form, out of these 4 different forms, they will all be analyzed the same way using the same criteria. The first thing you will look at is whether there is low T2 signal and low diffusion signal. Okay, here you see an ovarian, right ovarian mass where there is a cystic portion on T2, and you see this solid portion here. Now you will trust me that it enhances on contrast. I didn't want to show you it every single time, but it does enhance, so it's a solid tissue, and it is very low T2 signal. You see it is as low as the muscles here in the back. On diffusion weighted imaging, you don't even see that solid portion, so it's a low diffusion weighted signal. This is very important because if the solid tissue has both these characteristics, then it is always benign. If it doesn't, then you won't be able to know. I wanted to show you why it's very important to perform the diffusion weighted imaging with a high enough B. So remember, it's at least 1200, because otherwise you might still have signal inside the cyst. So this was an example of a lesion, a cystic lesion with this little solid tissue here that looks like it might be low, but you're not completely sure. And on the diffusion weighted image, and this was done a long time ago with a B that was at 800, or maybe 1000 actually, you see that the inside is still white, and you can't tell at all if the solid tissue has high or a low diffusion signal. So that's why it's really important to have that B. So if it doesn't have low T2 signal and low diffusion, then you will use the perfusion analysis. The way you do it, so you have your perfusion acquisition, and you're going to draw a region of interest on the outer myometrium and one on the solid tissue portion. And you're going to look for the one that has the worst looking curve. Perfusion curves can have 3 different aspects. Here you see on this darker dotted line the myometrial curve represented here. And so this will serve as a reference tissue. Okay, there are 3 types of curves. The first type is type 1, and this is a very low and slowly enhancing curve. The point of this type 1 curve is that it has a very high negative predictive value for cancer. So basically, if you see this type 1 curve, it's a benign lesion. The second type of curve is the type 2, which is characterized by the fact that there is an initial enhancing slope and then a plateau. This enhancing slope will occur after the myometrium, so this is a type 2, and I'll get back to this. And the type 3 curves are curves that start enhancing before the myometrium. Okay, so if it is the case, if it enhances before the myometrium, then it is a type 3 curve. Whether it ends up higher than the myometrium or lower than the myometrium, that does not matter. What matters is the fact that it starts before. And in this case, in more than 95% of the cases, these will be cancers. Okay, so type 1, they're benign. Type 3, they're cancers. The thing is, if you have a type 2, then you get basically a kind of indeterminate lesion. You will not be able to tell if it's benign or malignant. So if we summarize, and this is taken from a paper, the paper that I cite for those perfusion curves, what are the benign criteria that we will find? If it's purely cystic, purely hemorrhagic or endometriotic, purely fatty, no wall enhancement, no solid tissue, or if there is solid tissue, that solid tissue has low T2 weighted and low diffusion weighted signal intensity, or the curve type, it's a perfusion curve type 1. If any of these criteria are there, then you're very confident that this is a benign lesion. On the other hand, if the lesion is has a solid portion, and here I'm introducing some morphological items for the fact that it's a big lesion, but I wouldn't count too much on that. The higher the locularity, the fact that there's group septa or thickened irregular septa, if there is a perfusion curve type 3, and of course if there are peritoneal implants, then there is a very high likelihood that it is a malignant lesion. But you see that the likelihoods are not very good for all the morphological criteria, but very, very high for the perfusion curve. Okay, and of course, once again, if there's peritoneal carcinomatosis, then you're quite confident that it is a malignant tumor. So in the end, you're going to end up with an ORADS score, which goes from 1, where there is no mass, to 5, where the mass is probably malignant. Okay, so 1 is no mass, 2 is 100% benign, 3 has a very high probability of being benign. ORADS 4 is that kind of indeterminate part, and then the ORADS 5 are very highly probably malignant. Okay, so you see that this highly resembles what you find in the BI-RADS in breast imaging. Here's the way you're going to, so here's the algorithm, and the best thing is just to have this in your pocket because you're really going to just follow it, and I'm going to show you some examples. Don't be surprised it says a next MR score here because that was the score that was built before it was validated by the American College of Radiology. So before we were allowed to use the term ORADS, but it's exactly the same thing. Now, let's see some cases so that you understand how we read this. First case, you see this lesion that has several loculi. On T2, they're high signal. On T1, you see that they have different kinds of signal, so that's in favor of a mucinous lesion. You see this portion, and you're going to wonder if it is really solid tissue. So you're going to look at the post-contrast. This is actually a subtraction, which shows you that there's no enhancement, so it is not solid tissue. You can also notice that there's wall enhancement. So how will you read the ORADS algorithm? Well, there are no peritoneal implants. You have to believe me on that one. There is no solid tissue. It is not purely cystic because there are portions that are that have different T1 values. So let's put that in other masses without solid tissue. There is a wall enhancement, and so in that case, it's an ORADS 3. And in this case, this was a mucinous cystadenoma, so it was a benign lesion. Next case, a T2, a postmenopausal asymptomatic woman who had an ultrasound that showed that there were cystic lesions. You see that they're bilateral and that there are portions here that have very low T2 signal. On T1, there is no particular signal. You see that there is low diffusion weighted signal. Just for the sake of it, we did a perfusion curve, and you see that this is myometrium, this is solid tissue. The perfusion curve is a type 1 curve, so you're very confident that it's benign. Let's go over the ORADS score. No peritoneal implants, presence of solid tissue, but with low T2 and diffusion weighted signal, so this is an ORADS 2. And it was a cystadenofibroma. Next patient, here a cystic lesion with a solid portion. This is just the T1 to show that it's cystic. You can definitely see that it is not low T2 signal. It's intermediate signal, and it is not low diffusion weighted signal. So you do a perfusion curve on the solid tissue. You see this is myometrium. You see that the solid tissue enhances before myometrium. So this is a type 3 curve. So if we go over this, no peritoneal implants, solid tissue, other masses, type 3 curve. This is an ORADS 5, so highly suspicious of malignancy, and it was a serous cystadenocarcinoma. Okay, so the most frequent type of ovarian cancer. Regarding purely solid lesions, I'm going to show you 2 different cases just to compare how you would analyze them. This is a patient that has bilateral solid ovarian masses here. You can notice right away that they're irregular. You can also notice there's ascites, but we'll get back to that. In this patient, it was unilateral. Here's the uterus. This is the other ovary that had a cyst on it. Here are the diffusion. Neither of them, by the way, have low T2. I'm showing you the diffusion sequence, though the fact that it doesn't have low T2, well, it doesn't really matter how the diffusion signal is. And here are 2 different perfusion curves. In this case, you see myometrium and the solid tissue that enhances earlier than myometrium, type 3, so you know it's malignant. And in this case, you see solid tissue that barely enhances, so type 1, therefore benign. And in the first case, these were ovarian metastases of a breast cancer. In this case, it was an ovarian fibroma. Another case here, so a woman who has a kind of really complex bilateral cystic lesions. You see part of it has high T2 signal, but you also see these papillary projections here. So they're actually external papillary projections. This is the sagittal acquisition with 2 different slices where you can very nicely see these papillary projections. They're obviously not low T2 signal. They are not low diffusion signal either. Here's the post-contrast sequence. The reason I wanted to show you this case was that what you're going to do is you're going to perform several curves on all the different parts of the solid tissue to try to find the one that is the worst prognosis, right? So you see that you can get very different curves, so you want to find the worst one. And actually the worst one would be this, this red number 5 curve here, which is probably still a type 2 because it doesn't quite start before the myometrium. So it basically, actually all of these except maybe this one are type 2 curves, even though they don't go quite as high, each of them. So this was actually a borderline serous carcinoma. Now the interesting thing is that when you actually paid attention, and I don't know if any of you saw this, but there was actually also a uterine carcinoma, an endometrial carcinoma. But I mean that's just because this is the specific case. If you want to read up on this, here are the references that you definitely should be looking at. So this is the ORADS reference that you can read, of course, because it will go through how an international study allowed validation of these criteria for prediction of ovarian cancer. And if you want the ORADS to be explained to you, it's very well done on the American College of Radiology website. Here are the links to go with the description of the lexicon terms so that you make sure that you really understand what is meant by low diffusion signal, for example, or solid portion versus solid tissue, etc. And in the second link, you will have the risk stratification table that justifies why we can use ORADS. So in conclusion, just remember, even though this was a course on MRI, remember that ultrasound is the reference for ovarian mass diagnosis, at least the first line examination that you will perform, because it will allow you to recognize the most frequent benign lesions. It will allow you to avoid follow-up or MRI of functional lesions, and then you will refer to MRI any indeterminate mass. MRI has a very high performance to predict benign versus malignant ovarian lesions when using the ORADS score, because it will help the surgeon decide exactly how he will operate, and it will also prepare the patient to the result. But if you want to use the ORADS, you must acquire all the sequences. That's very important. And then there's something I did not mention because I don't have time to go into everything, but be careful. There are some kind of pitfalls. You should not apply ORADS to normal ovarian parenchyma, to corpus luteum, to pelvic inflammatory disease, or to the solid portion of a teratoma, because if you do, you're going to get type 2 or type 3 curves, and you're going to think you're looking at malignant lesions, which is obviously not the case. So this does mean that you have to be able to recognize these lesions or normal, actually, structures so that you don't make the mistake. And thank you very much for your attention.